Thank you, Banshi. Thank you, Rakesh, Rajiv, everybody, for wonderful reception that I got. I always get such reception. I'm very fortunate to get that. Um, and this is a pleasure to be in front of you, um, hosted by Banshi and team, and in this beautiful city of Ahmedabad. Each time I come, I see the city much beautiful, more beautiful than before. The topic is of great importance because almost everybody here, almost everybody will have fatty liver. So what do we do about it? This is what we are going to discuss. Uh, this is my disclosure. My research team, Ritesh is right here from the research team, and we have been researching non-alcoholic fatty liver disease or MASH, which is called now, for over a decade. A little bit of background, nomenclature, and prevalence to give you a context what we are going to talk about. These are the risk factors for hepatic steatosis. The excess body fat is the most important. And why I have outlined excess adiposity, because we Indians have a lot of excess adiposity. And also we have subcutaneous and intra-abdominal adiposity, which contribute to free fatty acid and fatty liver. There's another additional point here, which has not been taken in account as far as the research is concerned, is body fat muscle mass ratio. I think we should research more. Metabolic syndrome, lipodystrophies. I worked with on lipodystrophies in UT Southwestern when I was there, and these people have congenital lipodystrophy. Patients have huge fatty liver cirrhosis. Age and gender are predisposing factors. Asian Indians, in particular, have high prevalence of fatty liver. There is plenty to talk about, and we shall go on to diet in a bit. But suffice to say, refined carbohydrate, fat, trans fatty acid are some of the factors. Physical inactivity and heritability. This is important because when I see a patient with fatty liver, I will always ask whether your parents had cirrhosis or anything. Heritability, and specifically PNPLA3 we have researched about, but I don't think time permits for the presentation on PNPLA3. Now, anybody in the audience will tell us which is the greatest amount of free fatty acid which comes and gets deposited in the liver from where? Anybody? Rakesh says abdomen. Anybody? So say I give three options to you. One is adipose tissue, other is diet, and third is intrinsic formation of fatty. Intrinsic. So this is the metabolism. So look at this. 59% from the adipose tissue, and that's why intra-abdominal fat, subcutaneous fat, and total body fat is important. 15% from the diet, though it is very, very important, but still 15%, because ultimately diet will determine your adipose tissue. But 26% intrinsic, some metabolic defect. So these are some of the factors I'll talk about. Now, progression from healthy liver to fatty liver is approximately 25%, more so in Indian population. And then around 6 to 10% will have non-alcoholic steatohepatitis, and some portion, small portion, will go on to develop cirrhosis or even cancer. Now, the new nomenclature, metabolic dysfunction associated steatotic liver disease, find as presence of hepatic steatosis with one or more cardiometabolic risk factor. No other identifiable cause steatosis. Then there are other similar change in nomenclature, MASH here, metabolic risk factors, with alcohol, ALD, of course, ALD. This is the prevalence worldwide of fatty liver. I think these are conservative estimates. These are not exactly in actual estimates, especially for South Asia. The current estimates are around 1/3 of the population, but it possibly is more than that. This is our research paper in metabolism, global burden of metabolic diseases from 1990 to 2020. And this is a high impact factor. We are very pleased that we looked at the number of factors and change in top 5 countries with high burdens of common metabolic disease from 1990 to 2021 based on disability adjusted life years. And if you look at just three, and I've outlined them. Type 2 diabetes, I don't have to say anything about it. Obesity, we are number 2 at the moment in terms of overall dailies. Metabolic associated steatotic fatty liver disease, we are number 1, 2021. 1990, not much research had. This is our data which we published some time back, in 3 years back to be precise. We looked at the people with type 2 diabetes and those who are obese, diabetes duration of 9 years. So, and look at this is just ultrasound. This slide is ultrasound based. So a grade 3 fatty liver in 85%. So the number of people, type 2 diabetes people with fatty liver is very high. But more importantly, if you look at the FibroScan based data, this is the FibroScan based data. I'll come to FibroScan in a minute. Only 39% of the people had no fibrosis. So nearly 60% of the people had some fibrosis or the other. So those who say, oh, doc, I don't feel anything. No problems. My digestion, first they relate digestion to the liver. My digestion is okay. Everything is okay. You look at their liver, there is fibrosis. Then you have to make them understand that this is something which is related to mortality and further progression to cirrhosis. Now, this subsequent slides are based on the consensus document which we have created and which is going to be published soon. And this is specifically for Indian population. I'm not talking about the world. I'm not talking about non-T2DM people. Only for T2DM. And if you look at all the consensus guidelines throughout the world, there's hardly anybody who has written on consensus on people with T2DM. Now, measurements are very important, physical measurements. And if the patient comes to you, a BMI, a waist circumference, waist height ratio, acanthosis nigricans, a palpation of the liver, these are terribly important. If you look at the international guidelines for non-T2DM fatty liver, nowhere, it is surprising, it is mentioned that a good physical examination is something required. And then biochemical parameters. That brings us to our recent publication in I'm part of the Lancet Revised Obesity Guidelines and Indian Revised Obesity Guideline, both. So this is the Lancet and this is because this pertains to fatty liver also. Now, for those who are not into this, please download. Both are free to download and look at these papers. Now, this is the simplified obesity new definition for Indian population. Stage 1, nothing much except excess BMI. Stage 2, everything else. So abdominal obesity also, the related disease, non-alcoholic fatty liver disease is one of the commonest. And of course, physical symptoms. So that's a stage 2, and the difference is lifestyle modification here and lifestyle modification, weight loss inducing drugs. So you may use weight loss inducing drugs starting at 23 BMI. There is no overweight category here. No overweight as compared to the previous guideline 2009, which we made in 2009, no overweight category. This is particularly important. I wanted to show you because this is the only study in the world to show that if you look at the neck of the person and look at acanthosis nigricans, you look at the liver straight away. So this is the beauty of clinical examination. Look at the neck, please look at the liver. This was published 1 year back. Now there are other ways of measurement, and this is written in our current document, which we are going to, which is accepted for publication. This is the simplest, FIB-4 relation between age, AST, platelet count, ALT, and less than 1.3, no fibrosis. 1.3, 2.6 significant fibrosis, 7 cirrhosis. Now, this is not accurate, certainly not accurate, but nearly there, at least a guide to your investigation. But I think, more important guide is the vibration controlled transient elastography, the commonly named as FibroScan. That is the commercial name. That's why I've not used the commercial name. And look at a person whose report is right here, who has significant fibrosis. 12.4 is the KPA. So KPA is right here, CAP is right here. CAP is fat in the liver, KPA is fibrosis in the liver, and less than 8, 8 to 15, more than 15. Very simply. Again, not accurate. There are several factors like marked obesity, ascites, which may cause problems to interpretation. Now, this is the algorithm. Now, if anybody wants to take a photograph here, you can take a photograph because this is from the consensus document. Patient with T2D with high risk features of significant hepatic fibrosis, metabolic syndrome, obesity, acanthosis nigricans, long duration of diabetes, low resource setting, use FIB-4. High resource setting, use FibroScan. And then according to FIB-4 of FibroScan, which I have the limits of which I have already told you, high likelihood of cirrhosis, when to refer to a specialist, when to manage own. So screening. Now this is the consensus statements which are coming in. And I have highlighted those which are important. All patients with T2D should be screened actually, but those who have high risk factors, you better go ahead and screen more. Clinical evaluation, all should have BMI and waist circumference and calculation of waist height ratio. Look for acanthosis nigricans, I have told you. Hand grip measurement, if you have the apparatus, look for sarcopenia. And then metabolic syndrome, long-standing or diabetes, poor, etc. Go ahead and do more. And HCC surveillance is required for fibrosis. Now coming to the management, lifestyle management. Weight loss is of leading importance. But most of the, as I told you, are going to be obese. Stage 2 obesity. 5% weight loss to achieve regression of steatosis, and then 7% and 10% for resolution of MASH and reversal of fibrosis. Reversal of fibrosis may occur. It's not something which is unachievable goal. It can occur. A minimum of 150 to 300, I say 300 for Indian population, much more than the Western population, and in conjunction with resistance exercises. Diet, always a contention, always controversial, always debatable, but these are some of the common points. Non-starchy vegetables, broccoli, etc., whole grains, coffee. Important, coffee, more than 3 cups a day actually causes resolution of some of the fat in the liver. And there are a number of other issues, but foods to avoid are high fructose food, processed sugars, ultra-processed food, alcohol, even a small amount of alcohol. Then healthy diets continue. Monounsaturated fat, omega-3 polyunsaturated fatty acids, oils, certain oils which are good for liver, nuts and seeds, cooking methods, etc. What is bad is saturated fat, ghee, coconut oil, palm oil, butter, green animal fats, etc. Red and these are all available in the document. Now, coming to anti-hyperglycemic drugs and other drugs in the management. We should try to maintain less than 7 A1C at all accounts. Now, these are the commonly agreed anti-hyperglycemic. GLP-1 receptor agonist, SGLT2 inhibitors, high glutamate, and surgery. This is algorithm for management. Low risk, high risk, advanced fibrosis. For example, low risk standard diabetes care, GLP-1 receptor, dual GLP-1 and GIP receptor agonist, then SGLT inhibitors, pioglitazone, then the five here for all this for opinion, and also insufficient use for GLP-1 receptor dual with caution as GLT. Though not much of a data here and for here also. So be careful when advanced fibrosis compensated cirrhosis is occurring. P1 study, one of the best studies for liver fibrosis. Done by whom? By my colleague from All India Institute of Medical Sciences, Sanyal. Pioglitazone versus vitamin E versus placebo. Look, when the study was done, 14 years back, still stands as one of the best trials. Adults with NASH were taken, pioglitazone and vitamin E and with placebo, 80, 84, 80. Look at the alanine transferase going down, aspartate, aminotransferase. Insulin resistance was down only with the pioglitazone and weight was up only with pioglitazone. But more importantly, the total NFLD activity score was down with both vitamin E and pioglitazone. Remember, these people were on that. And resolution of definite non-alcoholic history of disorder. So, with confidence, you can use pioglitazone in people with type 2 diabetes. Now, what about SGLT2 inhibitor? This is our publication in Journal of Clinical Endocrinology and Metabolism in 2013. We looked at hepatic and pancreatic fat using MRI proton density fat fraction and look at the uncontrolled people with type 2 diabetes. And once we looked at the circumferences and scale font thickness and etc., weight was reduced by use of dapagliflozin, base circumference was reduced, total skin fold, meaning subcutaneous fat was markedly reduced, particularly important for Indian population. And hand grip strength very interestingly increased. So actually muscle power increased while the fat went down. But more importantly, liver fat reduction from 15.2 on MRI proton density fat fraction to 10%, 5% decrease, and also pancreatic fat. So pancreatic fat nobody has done as far as South Asia is concerned with SGLT. So this is a good, there are several other studies by my colleague Shafiq Kuche on EMPA from India. And then GLP-1 receptor agonist. Certainly, semaglutide resolves MASH, as has been seen in this particular study. But as far as fibrosis is concerned, there is a query. We are not definite about it. And similarly, if you look at the tirzepatide, this trial shows same decrease in the MASH. Fibrosis, not enough data. But there is one drug that has been recently approved, and that is the resmetirom. This has been approved by FDA for treatment of MASH, and clearly it decreased fibrosis. The time does not permit for me to discuss all this, but it is something which we look forward to when it comes to India. This is my final slide. You can take a photograph of this, because this is the summary of the treatment. If you look at the treatment here, we have no problems with pioglitazone. Non-diabetic people, a good drug. Bariatric surgery, clearly effective. Liraglutide, semaglutide, I have told you, proves histology, but fibrosis, there is a problem here. Look forward to more data. SGLT2 inhibitors, also. Resmetirom, FDA approved. Obeticholic acid, very good drug. Excellent. But LDL was increased and FDA approved. And there is a homegrown saroglitazole. Not too sure about it, never used it. Little shaky on this, and increases serum creatinine also. And then there are several others which have been used. For example, metformin, atorvastatin, UDCA, more of a placebos rather than anything. And ARB, pentoxifylline. All these, whenever possible, should continue, but they are not particularly beneficial. So once again, Banshi, thank you. Thanks, Dr. Chawla. Thanks. Dr. Parekh for producing such a wonderful document, very useful. And thank you.
Thank you, sir.